So coming on to the topic of excretion, we must know that this particular flow chart, so we have a glomerulus where there are efferent arteriole and there goes the efferent arteriole, and then from the glomerulus we get to have excretion. So see, there would be glomerular filtration occurring here. The net products will pass out from the slits and reach out to the tubular system. Now tubular secretion will be occurring and some part will also get reabsorbed, which is not meant to be excreted. So total excretion TE is equal to GF plus tubular secretion minus tubular reabsorption. Hope you agree with that. So the factors governing these three, that is GF, tubular secretion and tubular reabsorption, are the factors which will be affecting excretion of a drug. Let us make this very simple. Starting with glomerular filtration, you must be of the view what all things affect glomerular filtration, and you might come up with lipid solubility. No, that's not the correct explanation, because see, during the process of glomerular filtration, the substances are not passing through a biological membrane. They are simply passing through the slits created by podocytes and entering into the tubular system. So lipid solubility is not the concept to be used here. It just enters through the slits, and therefore lipid solubility is not a factor that affects GF. Rather, plasma protein binding and renal blood flow are the most important primary determinants of glomerular filtration here, as you would have seen in your physiology classes too. So when plasma protein binding kind of increases, the filtration decreases, and when renal blood flow increases, the filtration increases and excretion of a drug also increases at the same time. Now tubular reabsorption is obviously determined by lipid solubility and ionization pH, since it has to pass the membrane of the tubules to enter the bloodstream. So the concept of same drug, same medium will also apply here. So as whenever there occurs poisoning of an acidic drug, we carry out a process known as alkalinization of urine. What do we do here is we kind of alkalinize the urine so that acidic drug, instead of getting solubilized, gets precipitated in the basic environment and gets removed. So that is how we do alkalinization of urine. The reason for doing alkalinization of urine, hope that's clear. Now we move on to tubular secretion. So tubular secretion, this is occurring with the help of certain transporters. So plasma protein binding and the nature of transporters would be the primary determinants here. Plasma protein binding and nature of transporters. So you must remember that lipid solubility involves only and only tubular reabsorption. Now let us take a very great clinical example of penicillin. See, penicillin is completely excreted, very rapidly excreted from the body without having a great therapeutic effect. What do we do is we give proguanoic acid with it. So proguanoic acid kind of competes with the transporter and doesn't allow penicillin to get excreted. So penicillin again enters into the circulation and gives its required therapeutic effect. You must be remembering that if there is a kind of competition, so transporters would not allow penicillin to get excreted and penicillin will accumulate, leading to toxicity. But this is not the case here. You must remember this. We are very fortunate that penicillin is fortunately a safe drug. Remember this, that penicillin is fortunately a safe drug. Therefore, we do not develop any toxicity owing to this phenomenon. So we can safely administer proguanoic acid and penicillin together without having the toxic effects. Now let us discuss the concept of clearance. This is very important. this concept of clearance is very important for you to remember, that clearance is the volume of plasma from which drug is removed per unit time. Volume of plasma from which drug is removed per unit time. That is rate of elimination upon plasma concentration. Elimination means removal of drug from the body. Now see, clearance can occur. Drugs can follow two order of kinetics primarily, first order and zero order. There is also known as something called as pseudo zero, which means that the drug is initially, in case of pseudo zero, the drug is initially first order kinetics, but then it suddenly starts to follow zero order kinetics. So it is both first and zero order kinetics. That is what is meant by pseudo zero. Let us discuss some points related to first order and zero order kinetics. So see, first order kinetics, you must remember that constant fraction of drug is eliminated per unit time, whereas in zero order constant amount is eliminated per unit time. Do analyze these two statements and you will get to know what is the difference. Next thing, in first order kinetics, the rate of elimination is proportional to plasma concentration. Whereas in zero order kinetics, it is independent of plasma concentration. So first order, the clearance remains constant, whereas in zero order, clearance is more. Let me write it. Clearance is more at low concentration and it is less at high concentration. Most of the drugs follow first order kinetics, whereas very few drugs follow zero order kinetics. Example can include alcohol. Any drug at high concentration may show zero order kinetics, must remember that. And drugs whose kinetic changes from first to zero at therapeutic concentration are said to follow pseudo zero order kinetics. Hope you are clear with such terms. Another thing which I think we are leaving here is T half. So what is T half? T half is the time in which concentration half of the initial concentration is achieved. Time in which concentration half of initial concentration is achieved. Now this thing depends upon clearance. This depends upon clearance and volume of distribution. Suppose the concept of this. We can discuss the concept of therapeutic drug monitoring. Now, what is therapeutic drug monitoring? The process by which dose of a drug is adjusted according to plasma concentration. Let us understand this very carefully. Let's say we have a drug. Let's say if this is a person, how do we do TDM? So sorry for the bad illustration. The proportionalities of the extremities are not well met here. But let us say somehow this is the patient and we attach a lead into the plasma so that we can get to have a graph of the drug concentration or plasma concentration of the drug. Let's say this graph is, we need to maintain the plasma concentration of a drug at 50. Let's say we give a drug A and we want to maintain its concentration at 50. It's a very sensitive drug. By that what I mean is that if we are having levels less than 50, therapeutic effect won't occur at even 49.5. But if it increases to 50.5 also, toxicity of the drug will develop. So in such cases, we can adjust the plasma concentration to meet the requirements and qualify for the great therapeutic effect of the drug. This is only done for sensitive drugs, okay? By sensitive drug, what I mean is the concept of therapeutic index. What is therapeutic index? It's like a therapeutic window. Let's say a drug shows therapeutic effect only in a range like 50 to 60. So above that there will be toxicity, and below that it would be therapeutic effect won't be reached. So that is therapeutic window. So the drugs which are having low therapeutic index require therapeutic drug monitoring. We need to monitor the drug concentration and simultaneously adjust it so that best of the therapeutic effects can be reached. I think we have completed the concepts of pharmacokinetics, and hope this particular lecture was of help.